Hey everyone. My name is Kyle King, and thank you for joining the Research Roundtable for this month. As always, I'm a sophomore. Actually, that's not true. I'm not always going to be a sophomore. I'm actually 2 weeks away from being a junior, which is really scary. But I'm currently a sophomore. Interested in OCD for a couple of reasons. The most prominent of which is that I have the disorder myself, so I find the treatment and management of the disorder very interesting. And this is the Research Roundtable, a program where we try to sum up some of the current frontiers in the OCD literature that would take a lot of time to read if you were to scour the entire literature. But there are people in the world like Rachel Davis, one of our guests today, who know a lot about particular topics and we want to learn from. As always, I'm joined by my co-host, Jon Abramowitz. Jon, if you'd like to introduce yourself.
Sure, I'm Jon Abramowitz, and I will always be Jon Abramowitz. I am a clinical psychologist at the University of North Carolina at Chapel Hill, and I am along for the ride and kind of helping out co-hosting with Kyle, as we've been doing for, what is this, our fifth or sixth?
It's probably six-ish.
Something like that, yeah. And I don't know very much about our topic today, so I'm excited to learn and ask some questions as well. So I'm looking forward to this.
Yeah, I know very little about our topic, and I'm really excited to learn about it. But we'll get to that later. Our topic today is going to be neurotherapies. DBS for sure. Our TMS expert is having some technical difficulties. We'll see what happens there. But before we jump into that kind of stuff, I do have just some general announcements that I want to say first. So first, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you are in a crisis or if you're ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the suicide prevention hotline at 800-273-8255. Second, this is live. There's a comment section. We want to hear from you. If this is your first time joining, let us know where you're joining from. I like seeing where people are tuning in from. But also, we just want to remind all you guys that because it's live, everyone can see your comments. These comments will live on the internet. And we just want to make good educational content. So please keep the chat kind of cordial, be civil, and be kind. You know, living with OCD isn't fun. This is a disorder that can be triggering to talk about for some people. So keep it as civil as possible. But now, getting into the more meat of today's topic. Today, we're going to be talking about DBS for sure. So I'll start with DBS. I originally applied to Yale wanting to be a psychiatric neurosurgeon, which is kind of in the realm of what DBS is, I think. I read some articles about it. Okay, Rachel's shaking her head, so I know I'm on the right path. But I like to joke that Jon has consistently broken my spirit about psychiatric neurosurgery. So today we're going to learn if my spirit should actually be broken or if this is promising. And we're going to learn about it from our guest, Rachel Davis. So Rachel is an associate professor of psychiatry and neurosurgery. She's the vice chair for clinical affairs and strategy, the medical director of student resident mental health, and medical director of the OCD program at the University of Colorado Anschutz. Got it? Bam. Medical campus. She is service director for the Department of Psychiatry, Psychiatric Neuromodulation, and Advanced Therapeutics Services, and she specializes in deep brain stimulation for refractory severe OCD. Dr. Davis completed her undergraduate degree in medical school and psychiatric residency at the University of Colorado and has been on faculty at the University of Colorado for the past 13 years. She is currently a principal investigator on the NIH Brain Initiative studying the ethics of DBS in schizophrenia. Rachel, how are you doing?
I'm doing great. How are you doing?
I'm doing pretty well. Jim asked a question in the chat, which is also my first question. What is DBS, Rachel?
That is an excellent question. So DBS is deep brain stimulation. And deep brain stimulation involves implanting very thin electrodes in the deeper structures of the brain to provide an electrical current, so a small amount of electricity. And they're connected to wires that come down to the chest, to what are called pulse generators. They look kind of like pacemakers.
Okay.
And you can actually program those generators to change specific settings, to change the electricity, to change how you're stimulating the brain. Deep brain stimulation was initially used and is more commonly used for movement disorders such as Parkinson's. And then it's also has FDA approval via what's called a humanitarian device exemption. And we can talk more about that later if you want.
Yeah.
But for OCD, and OCD is actually the only psychiatric indication that currently has FDA approval for deep brain stimulation.
Okay. Wait, I have some follow-up questions, but first I'd like to introduce the other panelists for today. Joan Camprodon? Got
Correct.
it? Okay, cool. So Joan is going to be our TMS expert for the day. Joan, I hope you don't mind if I skip over the formal introduction and just introduce you as the mad scientist genius of TMS. But Joan is a chief at the Division of Neuropsychiatry and Neuromodulation at Mass General Hospital and associate professor of psychiatry at Harvard Medical School. Clinically, he's the founding director of the MGH Transcranial Magnetic Stimulation Clinical Services. So he is going to be our TMS expert. Joan, how are you doing?
Good. Hopefully the connection issues are clear.
Yes.
Now you can hear me and see me well. Yeah, great.
I can hear
Awesome. Yeah.
It was a browser issue, I think.
So Rachel just kind of explained to us basically what DBS was, and to be honest, I kind of understood it. It seems like what was the connection between the things on your chest and the electrodes in your brain?
Sure. So the things on your chest are basically, that's where the batteries are. And then that's also where you can connect to what's called a programmer. And you can actually wirelessly program from a tablet the different settings and the electricity. And so you can change things like amplitude, so how strong the current is. You can change pulse width, so how long the bursts are. You can change frequency, so all those sorts of things to get a specific shape and specific type of stimulation in the brain.
Okay. So they're kind of like a controller for whatever pulses are going on up here.
Exactly. Yeah.
And Joan, what is TMS and how are they different? And Rachel, that question for you too.
So TMS, like DBS, like ECT, like vagal nerve stimulators, these are all device therapeutics, right? So when you think about treatment in psychiatry, we have three main types of treatment. In psychiatry, neurology, we have medications, we have behavioral therapies, and then we have devices. And in the space of devices, we have three types of devices. We have devices that are surgical or invasive, like DBS or vagal nerve stimulation. We have devices that are convulsive. This means they are non-surgical. You don't need a scalpel, but you still need general anesthesia because you're forcing an artificial seizure on patients. This is not indicated for OCD, though. And then, so you have invasive or surgical, convulsive, and then you have the non-invasive techniques. And these are the ones that do not require surgery, do not require anesthesia. They're have the safest profile. They're often ambulatory treatments, meaning you go to a clinic, you get it done, you go back home. And TMS is in this later group of non-invasive ambulatory type treatments. Now, it's still a device, so and it's using electromagnetic energy. DBS uses electric energy directly. So with TMS, we have an electrical generator that is connected to a coil. It's a coil about this size, and then you place it on the surface of the scalp of a person or a patient. Depending on the condition you want to treat, you'll put it in one part of the brain or another, because not all conditions affect the same part of the brain. So for OCD, we may go here to the midline. For depression, we may go here to the side. for smoking cessation, for migraines. These are all 4 indications for TMS currently indicated by the FDA. So we'll place the coil on the surface of the head, and then the coil will generate a magnetic field. It's a brief and focal magnetic field. The magnetic field will travel through the skin, through the bone of the skull, through the meninges, which is the skin that surrounds the brain, through the CSF, which is the fluid that surrounds the brain, all the way to the brain. And once it gets to the surface of the brain, that magnetic field will convert into an electrical current, similar to the one we apply with DBS. And then that electrical current will force neurons to fire. And that electrical current will travel through what we call brain circuits. These are other neurons that are connected to the ones we're targeting first. And by using these electrical currents in the brain, we can upregulate or downregulate parts of the brain. We can upregulate or downregulate the connections between parts of the brain. And if we think about OCD and other psychiatric and neurological conditions as disorders of connectivity, so parts of the brain that are not efficiently talking to each other, or parts of the brain that are too active or not active enough, we can use these devices as a way to compensate for that. So if a region of the brain is not sufficiently active, we can activate it more. If, like in the case of OCD, a region of the brain is too active, we can downregulate it a bit more. And by doing so, we can use devices, but not medications or not behavioral therapies, or at least not just medications or just behavioral therapies, because all of these 3 types of treatments can be used in combination to modulate the OCD brain and help it be more adaptive in how it's processing intrusive thoughts or compulsions or rituals.
So it sounds like the primary difference then between DBS and TMS is kind of how invasive the initial kind of treatment is, because they end up both being electrical currents that manipulate circuitry in the brain.
You're right. So how invasive and what we target first, right? So the parts of the brain that you can target with DBS are deeper in the brain, and that's the limitation of TMS if you want, because TMS can non-invasively modulate the brain, but the more superficial part of the brain. It's not strong enough to go all the way through the skull, through the surface of the brain, to deeper structure of the brain. To do that, you need to open the skull and place the electrodes in the deeper structures. Now,
Gus, I'm sorry, go ahead.
We said that it's important to think that we don't just want to change one region or another. We really want to change how those different regions talk to each other, right? So it's about changing the circuit dynamics, that's the technical term if you want, which is basically the dialogue about brain regions, how those different brain regions together can compute brain functional information. So whether you hit it from a deeper structure like DBS or from a superficial structure like TMS, you still are trying to modulate that dialogue across brain regions, that circuit dynamic.
Yeah.
And another main difference is that DBS, because it's implanted, can be on all the time versus TMS as a treatment. You go in for a treatment, you go home, you come back the next day, you go in for a treatment. DBS is on once it's in the brain.
Okay. And like you just live with it for X amount of years?
Yeah. If you use the non-rechargeable batteries or pulse generators, they can last 1 to 3 years in OCD. There's a newer version that can last more like 5 years. And then there's actually rechargeable batteries that can last up to 9 years.
Okay. And then kind of, I guess, on the point of attacking like deeper brain structures, but versus going more superficially, what are like the general brain structures that we think about when we think about the neurobiology of OCD? And I guess, are they deep? Are they superficial? Like what should we be targeting?
All of the above. So they're deep and they're superficial, and they're cortical, which is the mantle of the brain, and they're subcortical, which are nodes that are kind of deeper in the brain. Again, all those different regions talk to each other, and when they talk to each other efficiently and fluidly, you can suppress intrusive thoughts, you can suppress the urge to engage in compulsions, but when that fluid adaptive dialogue doesn't happen, then you cannot inhibit intrusive thoughts, you cannot inhibit compulsions, and then they manifest in the form of symptoms.
How well do we understand all of this stuff? Because I gotta say that it sounds like we're just kind of blasting away and hoping for the best. My understanding of the literature is that, I mean, look, the brain is probably the most complex thing in the known universe. How well do we really understand what both of these techniques are actually doing in a person's brain? Well, I've read the studies. Sometimes we get, results, sometimes not, and sometimes not any better than a sham condition, but sometimes there are. But over and above that, do we know that how do we measure the effects that it's having, the specific effects that it's having? I threw a couple of questions in there, but I'm just curious, because my understanding of the literature is that we really don't, the literature on like the brain and OCD is kind of all over the place.
Yeah, that's exactly right. So we understand bits and pieces of it, but no, we don't have a precise understanding of how, and I'll talk specifically about deep brain stimulation, how DBS works. We know that it's been shown to reduce hyperconnectivity between the orbital frontal cortex and the striatum, so between the superficial areas and the deeper structures. We know there's hyperconnectivity in OCD, and using functional imaging, we've shown that when DBS is on, that connectivity is reduced. We know that. We know it increases dopamine in the striatum, but we know it probably turns on neurons, turns off some neurons, but how that all fits together and precisely how it works, we don't know. And then I think you asked, how do we measure it? And so, we do Y-box, we do rating scales at each programming visit, and we track that. And traditionally in the literature, they've defined a full response from DBS as a 35% reduction in Y-box. And we only use DBS in people who have very severe OCD. So these are people who have Y-box of at least 28. So that would be, a 35% reduction could be taking someone from the extreme range to the low end of the severe range, sometimes to the moderate range. And so it doesn't get rid of symptoms. People still have significant residual symptoms that they need to often use, medication, CBT, ERP, and other modes of treatment as well.
So we can measure the symptom reduction, but what about measuring to know for sure that it's doing what we think it's doing in the brain, and that brain stuff is actually related to, the symptoms of OCD? I mean, that kind of a reduction could be a placebo. It could be just knowing that you're going and getting some help and doing this complicated surgery and all this kind of thing.
Well, so a couple of thoughts there.
Yeah,
I'll address the placebo one first. So there have been several randomized controlled trials where they do sham periods and have demonstrated that it separates from placebo actually quite well, which is impressive in patients who have tried and not responded to multiple other treatments. And personally, seeing people in the moment having stimulation turned on, it is remarkable. You get this half smile, you get, it's just visible change, even objectively. But what was the first part of your question?
Just how do we map back to, okay, we have this stimulation, we think it's, we know that it's doing X, Y, and Z to the brain. How is that able to be measured, that those things are happening, and that is related to intrusive thoughts, compulsive behaviors?
So this is really a cutting edge area of research. So we have a new type of electrodes that can also sense electrical activity as well as deliver stimulation. And in Parkinson's, they have a better understanding that when you have increased beta activity, so beta waves in the brain, that's associated with clinical symptoms. We don't yet know what waves or what brain activity is associated with compulsions. There's been some case reports studied. I know they're studying this at Baylor. They're studying this at Minnesota. Joan, I'm sure you have more to say about this, but we're getting there, but we're not there yet.
Yeah, I'm actually a bit more optimistic about this. I think, and certainly there are gaps in knowledge, but I think OCD among the different neuropsychiatric conditions is one where the pathophysiology, which is the disease mechanisms, at least at the circuit level, we have a reasonable understanding in the sense that there's been a number of studies that use different techniques that can measure brain activity or brain anatomy, and they can relate it to symptom severity and can measure how this anatomy and function change over time as a function of the clinical change over time. So we have a sense of the regions that are involved and the signatures within these regions are involved. We also have a reasonable sense about, again, with knowledge gaps, about how TMS or DBS change brain activity locally and distally. Of course, there's some knowledge gaps, and the ones that are more relevant to patients is putting together the optimal way of using these techniques, because there's the parameter space, meaning the parameters you can change as a clinician, is extraordinarily wide. Mm-hmm. So figuring out the optimal way, where to place it, what frequency of stimulation, what amount of current, for how long, the optimal way to engage what we call this target, to engage this maladaptive brain biology in the brain and move it in the direction of health so that the symptoms can lower. That's the tough part, right?
Yeah.
And that's where more of this mechanistic work is trying to get us to develop treatments less in the blind, but more using what we call biomarkers or understanding of neurobiology to inform how we can narrow down that parameter space to be more effective. But, sorry.
Kind of, I guess I was reading some of the like review papers about TMS in particular is what I'm thinking of. And it seemed to me like there were a lot of studies that placed a lot of different frequencies of stimulation on a lot of different parts of the brain in both hemispheres. And it seemed like you were just kind of taking stabs at it, like John said. So I guess how far are we in this quest to find the best place to do this and at the best frequency?
So the quest is never ending with you, because at the end of the day, OCD is not one disease, but it's many different diseases. And not only that, but the brain anatomy of many different individuals, even individuals without OCD, is going to be heterogeneous, meaning there are going to be differences. So at the end of the day, to really get the highest levels of efficacy and safety, we need to individualize treatments. And that's difficult to do, but that's kind of the direction in which we're going. How can we not just treat OCD, but treat OCD symptoms in one patient, and that may be slightly different than treating them in a different patient, because their brains are different and because the specific mechanisms that lead to their OCD symptoms are different. That said, in this kind of population-based understanding of the general mechanism of OCD, there's been two different strategies to develop treatment. One is more empirical, or basically like hoping for serendipities, where you know a certain intervention may have, for example, work for depression, but it worked for depression in patients with OCD. What about see if we can help with OCD? But the other strategy has been more, if you want, bottom up, or kind of trying to understand, okay, what is the neurobiology of OCD? Mm-hmm. What are the nodes that are affected? In what direction are they affected maladaptively? Can we push in the opposite direction and see if that's going to help patients? And in that regard, and because, as I mentioned earlier, it's not just this one brain region that is problematic in OCD, but it's a network, and a network by definition has many different regions. And what you want to do is to change the dialogue across those many different regions. There may be more than one strategy to change that dialogue. At the very least, you could go to each one of those different brain regions and try to either upregulate it or downregulate it, or help it to be more efficient or less rigid in its dialogue with other brain regions. Mm-hmm. So to do that, I think there's a space of potential options to try. And we have a couple, at least, certainly one that is clear by the FDA, but a couple other strategies that have shown to be effective and safe, and more effective than placebo. But they're all nodes that are part of this network of regions that we see are maladaptive with OCD. But sometimes we have to increase their excitability, sometimes have to decrease their excitability, depending on how OCD changes them.
And I guess
go ahead, Kyle. I'm sorry. Go ahead.
I was gonna ask. I forgot my question, John. Your call.
No, I was gonna say I'm just stuck on my reading in the literature is that we really don't understand what's going on, connecting the specificity of any sort of brain stuff to OCD. Studies are just all over the place, and the best that we have are these, imaging studies that there's all sorts of problems with the methodology. The results are all over the place. I'm just surprised to hear how much it seems like this treatment seems to rely on a really precise understanding of OCD that we just don't have. I'm surprised.
Well, I think it depends on what you put first of all for precision. There's lots of open questions, many open questions.
Okay.
But we're not shooting in the blank either. So there's a sense about, their OCD, their problems with inhibitory control. So the brain regions that control inhibitory control and executive functions are reasonably well understood. The dynamics, physiological dynamics, meaning the dialogue and the activation patterns, are reasonably well understood. We have models for that from rodents to monkeys to humans.
Yeah, but OCD is not a problem with inhibitory control. People with OCD can inhibit their behavior when they choose.
So their impulsivity is not one thing. The impulsivity is many different things. And inhibitory control is a function, a subcontract of executive function, where that can be applied to movement, can be applied to thoughts, it can be applied to behaviors, it can be applied to emotions. So emotional ability is a form of deficit inhibitory control. Tics are a form of inhibitory control, deficits of it. Now, there's some general structures that may play a role in the different forms of inhibitory controls, but there are lots of subtleties in how inhibitory control for emotions or for tics or for movements or for actions pans out and it's computed in the brain. And one of those forms is the capacity to inhibit compulsions, which is different than, for example, the deficits that a patient with TBI or a patient with mania may have in inhibiting emotions. And so to the extent that inhibiting the urges to engage in a ritual is maladaptive, then one may engage in that ritual. And if we can help that brain and that patient be more efficient in its capacity to suppress those urges, that's one of the different treatment strategies. All the treatment strategies are less focusing on inhibitory control modulation and more focused on fear learning and your capacity to downregulate anxiety, which is a consequence of fear, maladaptive consequence of fear. And that's how, for example, that's more the focus of other interventions like CBT, right? So again, OCD, like many other brain-based disorders, is not a disorder of a single domain or single brain regions. There's different things that are at play, but certainly inhibitory control is one, fear learning is one that is great, and the right balance between using habits versus using a more flexible, goal-oriented type of strategy to solve problems. It's, if you want, like a third domain where we see patients with OCD may have trouble, and we see the signatures in the brain regions that process that type of information that are aberrant, if you want. Again, we don't see that consistently. The literature is all over the place. We don't.
I'll stop because I want this to be a nice time.
Well, but Rachel, it seems like you have something to say as well.
I'm just going to say, I think it's worth pointing out that the same holds for ERP, for medications. We don't really know how they work. We have ideas, we have pieces of understanding. Like Jon is pointing out, the literature says all sorts of different things, all sorts of cool things, but they're not always consistent. And so when we're talking about neuromodulation or neurotherapy, do we need to have a higher threshold for when it's okay to proceed with treatment because we're doing something that we don't really understand? And with therapy, the risk is relatively low, right? With CBT, ERP. And so there's a lower threshold for needing to understand exactly what's happening. With medication, the risk is a little higher. And then with TMS, the risk is actually not really any higher than with medication. So, I kind of think about TMS and medication on the same sort of safety profile. And then DBS, that's brain surgery. And so when do we proceed with something that we don't completely understand, that we know a little bit about, and that we know can really help people? DBS really needs to be reserved for people, and it is reserved for people who have tried and not responded to all of the standard treatment.
Right.
So someone would not be a DBS candidate unless they have tried adequate CBT, ERP, lots of different medications that work on serotonin, including clomipramine, at max dose for at least 12 weeks. Other medications like antipsychotics, benzodiazepines sometimes. And they need to remain severely disabled. So a Y box of at least 28. And often, the people or the individuals I work with have Y boxes in the 30s and higher. And they need to be disabled from their illness. That said, sometimes people are actually too ill for DBS because DBS is a very complex process and procedure. Someone needs to be able to come into the office. They need to be able to adhere to treatment consistently. They need to be able to go to the hospital. So someone who's so ill that they're stuck at home is probably not a good deep brain stimulation candidate. They also need to be able to tolerate a lengthy evaluation process. And so sometimes people with very severe OCD feel desperate. And DBS is not a procedure that should be done out of desperation. One, it takes a long time to be evaluated. It takes a long time for programming. It's not an instant response. And two, it doesn't work all the time. So we have about a 50 to 60% response rate with DBS, but that means about 40% of people won't respond. If you have someone going into DBS surgery, seeing this as their last hope, and who doesn't have a realistic understanding of the process and the potential benefits, that can be devastating. We also don't want to do DBS in someone who's actively suicidal. If someone's suicidal and they see DBS as their last hope and then it doesn't work, that's a very, very bad situation. So we're very careful about screening and who's an appropriate candidate, and make sure that people have realistic expectations, because DBS is not a fix. People will still have significant residual symptoms. They will still need to engage in ERP intensively, in fact, to make benefit. And what DBS does is sometimes it gives them the bandwidth to actually engage in the treatments that can then help them move forward.
So I from the perspective of a patient, because it seems like a lot of people in the comment section are people who are kind of more like me, just trying to get a general sense of this kind of stuff and maybe not so bogged down by the neurobiology of it all. You said that there's a 50 to 60% response rate for DBS. What does that mean, like, exactly? So like 50% of people see 35% reduction in symptoms, or like what's happening? And the same question goes for TMS after.
Yeah, so 50 to 60% of people see at least a 35% reduction in Y box. And so,
okay.
And these are people starting out at 28 or higher. So that would be...
So 28 on the Y box, just for people who are unfamiliar, means approximately what, John?
So the Y box goes from 0 to 40. And yeah, if you're up in the upper 20s, and into the 30s, you're pretty paralyzed from OCD. Pretty,
so that's like
severe extreme.
That's moderate to severe impairment.
Severe to extreme impairment. Yeah.
Yeah, and so DBS could bring someone down from the extreme level to the low end of severe level. So you've still got someone with very severe symptoms. Now, I have had patients who go from the extreme level to the subclinical level. That's not the norm. It's possible. But people really need to understand that they're going to still have significant symptoms after DBS. They just may have a little bit more room to push on those symptoms and work on those symptoms.
Okay. So you see, for about roughly half of patients who try this, they see this reduction. And TMS, is it about similar, about roughly half? Where do the numbers lie?
So it depends on what literature you're looking at and what target you're going for. But it's generally a bit lower than that. It's going to be more in the 40%, 50%, but more, high 30s to to low 50%. That's the range of response rates. Again, right.
So it's a little bit lower than DBS.
Correct.
And for both of these, if I'm a patient and I'm thinking about these, I mean, I know they're both not first-line treatments, but how safe are they? Like, particularly DBS, that sounds scary.
I mean, there are risks. The main risks with DBS would be hemorrhage, because you're going through brain tissue. The numbers are small in OCD, so looking at the more general literature in Parkinson's, the risk of hemorrhage ranges anywhere from 0.6 to 13%, depending on the literature. The other main risk is infection. And obviously infection of something going into the brain is bad, and sometimes that results in having to have the equipment removed. And then you have, so those are the probably two most serious potential adverse effects. You can also get seizures. Seizures are more likely to happen shortly during or after the procedure and not necessarily be an ongoing thing. They're also uncommon. And then you can have stimulation-related side effects. And so, but the thing about stimulation-related side effects is you can address those or mitigate them by changing the stimulation parameters.
Okay. And TMS, I mean, is this generally considered safe as well?
Right. So TMS, it's a safer intervention. It's a non-invasive intervention, so there's no surgery, there's no anesthesia. There's a couple of absolute contraindications for TMS. So you don't want to do TMS in a patient who has metallic implants in the brain. So someone who had a brain surgery for, let's say, a vascular malformation, they have an aneurysm clip, or someone who has a DBS system implanted, or someone who may have a cochlear implant. So because the magnetic fields can interact with that hardware, and that can be problematic. It used to be that if you had a cardiac pacemaker, that was also a contraindication, not anymore. There's things you can do to treat patients who have cardiac conditions, rhythm conditions, and but there are some side effects that are less concerning and more common, and this could be, the coil, there's a clicking noise and there's a tapping sensation. It's generally not painful, but there's a small subset of patients who will find it uncomfortable, or a smaller subset of patients will find it painful. It's generally not a headache. It's generally more like local discomfort under the coil. But it can also lead to headaches.
And that's only when you're undergoing the procedure, though, not after?
So the discomfort under the coil is only while you're receiving the procedure. A more standard headache may happen after, once you're done with the procedure. Now, that often has less to do with the TMS itself, or the kind of the electromagnetic energy, and more with the fact that you may be holding a position, and if your head is not fully supported in a way that is very comfortable, if you're holding a position for 30 minutes and your neck is too tight, then that may lead to cervically originated headaches. So just because your muscles may tense up. There's also, depending on how you practice TMS, one way of doing it is you may wear a swimming cap that helps us make some drawings and get some references in your head to define where we're going to stimulate. Those swimming caps can be tight. They should be tight so that they don't move and we don't lose our reference. But if they're too tight and the person is sensitive to that, that can also lead to a headache after stimulation. Now, these are headaches that if you take your analgesic of choice, ibuprofen, whatever it is, then they should go away. Other things to consider are, there's a clicking noise. So in the older literature with the older coils that were louder, there were some concerns with potential injuries to your hearing, so some hearing loss. That was never fully demonstrated, but these kind of things are, even if it's not demonstrated, let's just assume that it can cause that type of harm and protect.
Better to be on the safe side.
Exactly.
There was an interesting question pointing out that there are private TMS businesses popping up, and is it a good idea to use those, or should it be in a real psychiatric hospital?
So I think it's generally these days a good idea to go to these private clinics in the same way that you don't just have to go to an academic hospital to be treated with medications or behavioral therapy. So interventions like TMS have become mainstream to the point where, in the same way that you may go to a community hospital, to a private practice to see your PCP about your diabetes and your hypertension, and you may go to a community practice to see a psychiatrist to treat you with medications, or to do psychologists or psychiatrists to do CBT, it's reasonable to go to these types of non-academic practices. Now, of course, there are going to be differences between a smaller private solo clinician doing TMS and a larger center in a university setting. Not all patients have access to these larger centers because they may not be close to a large university hospital, or because it's just more convenient for them to go to a place that's close to home, and they can work or study or do other things more efficiently. And like always, here the detail. So anyone who's licensed with the right credentials, you can assume that they are sufficiently trained to be able to provide good quality care, including with TMS. That way, it's not different than any other form of treatment, but they may be different. So you just want to do your research.
DBS is a different story.
Yeah.
You want a highly specialized team at an academic institution who has done this preferably many times before.
Yeah.
Absolutely.
So I guess this is a question that I feel like is really important for both DBS and TMS. Let's say, like, what kind of patient would both of you suggest consider these kinds of options? Rachel, you made what I think is a really good point in that, like, these are not your first line options, right? You go for ERP first, or maybe you try more standard medication. So at what point kind of in your treatment do you start considering something like DBS or start considering something like TMS?
Well, I'll start with DBS. DBS, you really want someone who's tried everything, and they've tried everything, like really tried everything, not just kind of tried ERP, that they really engage with ERP with someone who knows how to treat OCD.
Yeah.
And they've really taken medication, not someone who's taken tiny doses of an SSRI. They really need to have taken max doses above the FDA recommended dose, and they need to be severely impaired and severely suffering, because there are some risks. It's as a surgery, it's a fairly low risk surgery, but it is a brain surgery. So you need someone who's significantly ill, has really tried all the other therapies, and continues to suffer a lot.
Okay.
Yeah, so clearly their thresholds are very different for DBS and for TMS because of their safety profiling. I think in DBS, as Rachel mentioned, you also want these academic centers where you have generally like a committee level decision making, just like tumor boards for cancer. So you have these psychiatric neurosurgery committees where different clinicians, surgeons, psychiatrists, others are evaluating the patients. And when we sit in our DBS committee, I often feel that our goal is really to have like a third, fourth, fifth level, more sophisticated consult to try to avoid the surgery. Have they really not tried this? Have they really not tried that? Can we, if they got stuck with doses for these medications, could we try these other things to push them higher? And see if we can try less invasive options and get them well enough so they can function. But sometimes, some patients are very treatment refractory and they're very sick and very severe. And for those, then yes, we will consider DBS. For TMS, because the safety profile, as you said, is similar to medications, so you could theoretically envision starting a patient with TMS as their first line of treatment. Now, this doesn't happen for a number of reasons. One is that we have more years of experience using medications and ERP than TMS, so there's a bit more evidence of what to expect from general clinicians. There's also an insurance type of obstacle. So while TMS for OCD has been approved by the FDA, it's still at a stage, and that's normal for all treatments, where first the FDA says, okay, you can use this, and it takes a couple of years for the insurance companies to say, okay, I'm going to cover that. right? There are two different processes. They don't happen in line. First, it has to be approved. Then insurance companies have to accept it. And it's still the case where while most insurance companies at this time will cover TMS for depression because it was approved in 2008, OCD is more recent. So we're starting to see more insurance companies cover it, but there are many that still will not cover it. And when they cover it, they will often require that the patient has failed a number of medications. And while there may not be strong evidence clinically to support that, because OCD and TMS, like medications, like depression, like all conditions, the more treatment resistant you are, the more treatment resistant you are, meaning that the more treatments you have failed, the more we have to scratch our brains to figure out what can work, but there's a bit of a higher chance of a treatment not working. So if you just fail one medication, TMS has higher chances of working than if you fail 10 medications. But that said, most insurance companies will impose a threshold, will say you need to have failed X number of medications. And then by nature of these kind of insurance-based conditioning factors, then you may not start TMS until you have met that requirement.
Yeah, and the rig. Oh, John, your question.
Oh no, I was gonna follow up on one of the questions that came up in the chat. Go ahead.
Oh, was it good? I think it's going to be the same one I was going to say. What were you going to say?
About long-term. Yeah. Tell us about the long-term effects. Is this kind of one and done, or do people need to go back and continue to get treatments? I guess it's a little clearer with the DBS because that's a long, the stimulation stays in there, and that can get, you can turn it on and off. But what about with TMS? Right.
So I think we're still learning about these long-term effects in OCD. We know more about it in depression, and there's certainly a number of patients who have the one and done. But it's also not uncommon for patients to need to come back a year and a half, 2 years, 3 years later, because their symptoms are resurfacing. Now, something that so far seems to be more consistent with TMS is that, unlike with medications where you may come out with the right combination of medications for a patient and they work for 3 years, and then something happens and they stop working and you don't fully understand why, but they stop working, so you have to reconfigure things. With TMS, if you responded once, then it's very likely that you will respond again to the same type of intervention. So it's less likely that this kind of effects, when the benefit disappear, will be seen. But again, we don't have 20 years of experience with TMS for OCD. We do have more than 20 years of experience with medications for OCD. So I think some of these long-term dynamics and how patients respond and come back, I think we'll just need to continue following patients and learning more from them.
And for DBS?
Well, given that DBS is always on for many patients, it continues to be effective. Now, there does seem to be some degree of habituation where in some patients the level of current stops being as effective, and people end up having to increase the voltage over time. I have found some ways to mitigate that. Some of my patients can tolerate turning off DBS at night, or one side off, and they alternate turning off one side each night, and that has seemed to kind of preserve some of the benefit. They do that they use DBS an essential tremor, so a tremor disorder, and people with essential tremor turn it off at night, and that preserves efficacy. So I think of it kind of like if you took Adderall 24/7, like it would stop working as well, right? Now that's kind of a false analogy. It's not that simple, but if DBS is on 24/7, your brain kind of adapts, and it doesn't quite sometimes work as well. And so, but generally, the effect doesn't go away completely. It still remains effective in people who it's been effective in initially.
Okay. John, you like the answer to that question?
So, great question. I got kicked out somehow, but now I'm back. I was going to ask, so you mentioned, Rachel, that DBS started with Parkinson's, and that's interesting. So how did the idea to use it for OCD even come about?
It came about with the idea of, OCD being a disorder of the corticostriatothalamic-cortical circuit, and that maybe we could stimulate areas within that circuit, and it might help. And it was also came about due to the history of lesioning brain surgeries. So surgeries where they went away again.
Yeah.
Surgeries where they actually destroy some tissue, and probably kind of 1950s is when people were doing a lot of brain surgery without a lot of regulation, but they did find that there were certain brain surgeries that were effective for OCD. And so the sites that we stimulate with electricity are similar in location to the sites that have previously been found to be effective in OCD with lesioning procedures. Actually, the first people to try DBS for OCD, I believe, was Nutten and colleagues in 1999. Yeah.
And just kind of a wrap-up question for both of you. Where do you see these procedures going in the next 15, 20 years? I mean, do you as experts in these fields think that they're going to become more prominent? How much work is there left to be done to figure out how to make these things really more mainstream?
So lots of work remains to be done, that's for sure. And I think, I think the way we're doing TMS and DBS for OCD, it's still a treatment for the syndrome. So everyone kind of gets the electrodes placed kind of in the same place. That's kind of the target for DBS for OCD, or the target for TMS for DBS for OCD or TMS for OCD. But as I mentioned earlier, there's lots of variations in the brains of humans without any conditions.
Mm-hmm.
And once you add a disease factor in it, it becomes more concerning. And as I mentioned earlier, it's OCD, like all of the psychiatric conditions, they're clinical syndromes, which means they're not a single disease. There's different biological mechanisms leading to that clinical presentation. So trying to understand those individual differences and trying to adjust your treatment intervention to those individual differences, it's certain, which is kind of precision or individualized treatments. It's going to be, it's certainly a goal that lots of groups in the US and around the world are working towards, and we're starting to make some progress in that respect, such as, for example, I think there was a question about, do you need an MRI to do TMS? Well, not in the current form, but certainly, because the anatomy of the brain in different individuals is going to vary. It's an interesting
idea, yeah.
So having MRI-guided TMS is becoming more and more of a practice, and in some clinics, that it's true, it's going to be more in university-based clinics than in community clinics. And more evidence to suggest that if you can harness that heterogeneity across individual brains, your clinical outcomes are going to improve, which means there's less variability in your response and greater amount of response.
Yeah, but there's a lot of work to be done to make that a thing.
Correct. I mean, I think we're starting to explore that, and we're starting to see results, and you're starting to see applications of it in some real life clinics. But certainly, to have the evidence, understand all the pieces, it takes a lot of work and a lot of people working on it.
So you guys look at OCD and you say brain disease, period. Like, people with OCD have a disease of their brain. No. Rachel's saying no.
Yeah, Rachel doesn't like that.
No, I mean, it is a brain disease, but it's a brain disease influenced by someone's life and stressors. And
so what does that brain? So what does that mean as far, like, what does brain disease mean even?
Brain disease means that there are some changes to brain biology that explain the types and severities of symptoms, and that if we are able to modulate that brain biology that is associated with severity, we can modulate severity.
We don't have one piece of evidence that OCD is caused by something wrong with the brain, something abnormal about the brain. We have correlational studies showing from, MRIs that there is a relationship between the brain and OCD, of course, but no one, thank God, has ever taken a healthy person's brain, manipulated it, or manipulated, half the people, and half the people don't get manipulated, to see if they develop OCD. We know also that, as you're saying, Joan, that the environment can change the brain. And we know that when we take people without OCD or other sorts of anxiety and we stress them out, their brains look in the MRI scanner just like someone who has OCD or phobia or things like that. It seems very reductionist to just kind of say OCD is a brain disease. Certainly it involves the brain. I mean, we need a brain to have OCD, but there's no evidence that there's anything
that's
abnormal.
Heart disease, right? I mean, people develop heart disease because of their diet, because of lack of exercise, because of cigarette smoking. I mean,
okay. That's
but eventually the cells in the muscles of the heart are going to be pathologically changed. Right. And I think we just have a couple of minutes, and this would lead to a really a lot longer conversation.
John, you opened Pandora's box right now.
I know.
At the
very moment. I would disagree with that notion. Also, just the idea of what causality means. I think philosophers of science and neurophilosophers have been discussing it for a long time. But certainly here, what devices can offer often, and when we think about just even basic neuroscience research with TMS and the likes, is that you can move beyond correlations into causation, because you are changing the system and observing the effects. We've also been changing the brain with medications, and we're changing it with behavioral therapies. And there are mouse models, and there are all these types of animal models. But just with humans, the moment you can do TMS or give them medications, or even enforce a behavioral strategy, and you can see changes in brain activity or just brain biology that go hand in hand with changes in symptomatology, that gives you, in the causality is not a categorical thing; it's a spectrum on how you define causality. But definitely, that's what one would consider a causal explanation, because you're not just observing the system; you're just intervening in the system, and then leading to some changes.
Well,
we can get. My brain, all of our brains are changed as a result of this conversation. That doesn't mean that there's a disease.
Correct.
Well,
anyway, it's a
John,
fascinating discussion.
You're getting too high level.
I'm gonna,
Rachel, you go.
I like Rachel. Rachel, you make a really good point to heart disease, that it can be influenced by biology. It can also be influenced by environment. I think that's a really good point.
Right, and absolutely. I think what I was going to say is what we do have is we have twin studies where we know that between 50 to 68% of identical twins will have OCD if the other has OCD, but that leaves a good number there that don't have OCD. And so what are the factors that lead to one twin having it when the other one doesn't?
And twin studies have lots of methodological difficulties also.
Yes.
John.
All right. Hey, you wanted us to have some lively discussion.
No, it's fun.
It's fun. I think people enjoy seeing that, and I certainly it's really been interesting to kind of learn and kind of push these guys around a little bit.
I do think it's worth noting that Rachel said it herself, and Joan alluded to it, that these are things that you use in conjunction with ERP, CBT. I think both of you would agree that these are not. You should continue that behavioral therapy. That stuff that, as Joan said, we have a lot of years doing, and we know work.
Correct. It's about not being reductionist in any direction, about being all-encompassing. So you want to take everything that it's available to you, both in terms of explaining the problem, but also about solving the problem. So you have evidence for ERPs and for medications and for DBS and TMS to work. Hey, at the end of the day, we want to improve our patients' symptoms.
Amen to that. Amen. I think we can all agree with that.
And reductionist approaches, whether they're on the psychological or on the biological, are unlikely to lead to that improvement. So you
Yeah.
know, often, you know, there's no contraindication to use ERP plus medications plus TMS. You know, if you do DBS, you would not expect patients to stop their medications or to stop doing ERP if it's being helpful for them.
Yeah. Okay, so we're a little bit over, so I'll be a little bit quick in my general announcements. But thank you, everyone, for joining us. Thank you, Joan and Rachel, again. This has been a really fun one, and I did learn a lot.
Thank you.
If you want to hear about more research and stuff, the annual IOCDF Research Symposium in July is open for registration now. So you can go learn more about that and register at the iocdf.org/symposium. Also, really briefly, I'll plug the conference in general. It's actually in Denver, so we're going to be invading Rachel's homeland. Registration is open for the 27th annual OCD conference. I'll be there. John, I know, will be there. Learn more and register at iocdf.org/OCDcon. This live stream is also just one of many, so you can see the entire schedule and submit questions and suggestions for future streams at iocdf.org/peace of mind. If you want a topic for me and John to discuss, go ahead and submit your suggestion there.
Yeah.
And this has been recorded and will be put up on YouTube. I think it's also on Facebook. I'm not sure, but definitely YouTube. So you can go watch it again, learn more, show other people, have them learn stuff. Have them also get mad that John's bringing up deep philosophical questions with like 2 minutes left in the stream. But thank you all for joining again. This has been a fun one.
Take
Thanks,
care.
guys.
Thank you.
Take care, everybody.